Well, welcome everyone. We'll get started here. My name is Matthew Calandrello. I'm the Vice Chair of the NCCE, and welcome to this rendition of our resource sharing webinar. These webinars were born kind of from members just like us, trying to bring real life kind of current resources that we're using, whether it be in our academic or our clinical institutions, right to clinical education. We've heard about reflective practices, simulation, IPE, and the list kind of goes on and on. Today, we're going to hear about an innovative concept, which I believe is pretty awesome. And I really do think like the wave of where clinical education is going, the Master Adaptive Learner from Becky Bliss and Lindsay Holland from the University of Missouri. It's our hope that there are some nuggets in each of these webinars that people can take home, share with their colleagues, that can kind of be modified and implemented for what makes sense within your own program. These are always free webinars. They're ultimately going to get posted to the ACAPT YouTube webpage, which I'll share in a little bit. What I'm most excited about, and we were talking about this on the pre-call, is these are starting to get traction on the YouTube webpage. We're seeing 500-600 views of these, which to me means that clinicians are seeing them. So I think this content is really getting to the full clinical education community. If you haven't been on ACAPT's resource pages in a while, I'd encourage you to. There's lots of unique content that might spark some innovation within your own specific program. In the chat, I'm going to post kind of a host of different links. Some are, again, the links to ACAPT's YouTube page. Some are the NCC resource page. Some are upcoming webinars that we have, and some of the items that are happening at ELC related to clinical education. So do take a peek at those. I'll post some of those pieces into the chat in a few moments. A little bit of housekeeping, as I was just messing up my own mute button there. We're going to ask individuals to post your questions directly into the chat. We think we're going to kind of use most of the hour today. So myself, Lisa Black, and Jacqueline Carson, both from the NCC board, are going to be monitoring the chat to make sure we can kind of pose the questions directly to Becky and Lindsay as they go on. So I will join you again for a few minutes at the end. We're really excited to have them kind of speak about the Master Adaptive Learner. And off to you guys.
Thanks, Matt. So welcome, everybody. This topic kind of bred from several years ago, almost 2.5 now, maybe 3. We were trying to, Lindsay was really, her goal was to bring residency education to the University of Missouri, where we housed our own didactic and brought a neuroresidency to the healthcare system. And so when I came here to the University of Missouri in 2019, she had just gotten her NCS, and we met, and we always feel like it's kismet. We spend a lot of time together. But what really was great was we were looking at our didactic framework and thinking about, we should use a framework. What is that going to look like? And I had just finished my terminal degree where my dissertation topic involved the Master Adaptive Learner. So I was introduced to this in 2016 by Gail Jensen. She was on my committee, and I've been eating, and breathing it ever since. I actually teach this to post-professional DSC students for Bellin University. So I actually teach their 2 educational curricular courses where I'm teaching this to post-professional. And then fast forward a little bit, we designed everything. We went through our candidacy period. We've been accredited. We're in our 2nd cohort. And as we've learned over the last 2 years, this is something different, and it's working beautifully. We are seeing more growth in our residents by using this framework. It's been being used in American Medical Association education for a while now. That's actually where it was born. And, we said, well, why can't we be doing this with our entry-level students? And so we've got residency mentors that serve as mentors, but then also clinical instructors for our program as well. And so we have seen this kind of trickle down, and we'll talk a little bit how we've infused this into entry-level education as well. So that's kind of what our goal is for today. And then you can see your objectives. I do not need to read them, but we're going to talk about just the background of what is the framework, why is it important, what is it, base its premise on. There's some personal characteristics in our learners that we really want to foster as coaches. What does this coaching model look like? And then how do we translate this and transform it into all things PT education? So when we were first putting things together here with residency education, we had the Excellence and Innovation Model study that was published in 2017 that we knew that entry-level programs that had residency involvement were that excellence framework. And then we knew we had this master adaptive learning framework, and we wanted to mold it all together. So we really use contemporary educational practices to design our curriculum and our program. And so we were talking about this previously too. This was very timely. So I've been living, eating, and breathing this since 2016. We started our planning and implementation in 2019 here, and then here we are in 2022, where this is a call to action to infuse this educational framework into physical therapy education across the continuum. So it was perfect. When this got published, I was super, super excited. And so why do we need to use this new contemporary framework? Why is this so important? Well, as you all know, and especially if you're involved in Clin Ed, which most of you are either as clinical instructors or director of Clin Ed, we are putting our students out into a more complex healthcare environment than what we were originally trained in. They have to do more with less time, right? Less resources, less time, and they have to be adaptable for those complexities. We're asking them to be more efficient, to think on their feet, to be self-aware, to adapt when things aren't working. And it's that constant need for problem solving in the moment. And then also sometimes there's just not the resources. So we're being asked to be extremely innovative to solve typical problems that, wouldn't have solutions unless we think outside the box. And that's where this framework really plays off of, is development of these skills in our learners to survive this complex healthcare environment. The other premise that the Master Adaptive Learner framework really looks at is, how do we create self-directed lifelong learners, right? I think sometimes we think about some of our students and they're just, what can I do to survive? How do I just check the box? How do I just do what I have now? And they're not really forward thinking or worrying about the future, where this framework actually from the beginning implements implicitly the fact that all these skills are super important and they are very important for lifelong learning. And if we can teach you to be self-directed and innovative and identifying your own weaknesses or gaps and show you how you rectify those by yourself, then we're setting these individuals up for lifelong learning across the continuum when they graduate, after residency, after fellowship, and they become leaders in the field. And so the idea, by infusing kind of a blend of innovation and efficiency, is this optimal, corridor. So sometimes you have to, depending, on the situation, be highly innovative because of lack of resources. And other times, especially if you've had clinical pattern recognition, you've got, expert practice, you're very efficient because you've done that. The goal is to combine these two together and make it so that you can survive in this optimal adaptability corridor when you need it in clinical practice. So if you've never seen this little schematic, it's one of my favorites. So you can see there are 4 wheels, cog wheels, that interact, and it's cyclical, right? So during any interaction, whether, a new task is learned or in the moment of an interaction with a patient, all of this is happening. What I love about this, and what's very different, is if you look on the bottom of this, there's this little coach knob, right? So it's, how much do I need to coach? How much do I need to back off? It's like a volume control. And it's putting, by us being down at the bottom, the coach is the educator, the clinical instructor, the residency mentor. It puts the learner at the center, which is exactly what our excellence framework, looks at, the conceptual framework from that. And that we are coaching on the sidelines. And then those little 4-pack of batteries are the personality, characteristics that we're trying to coach to assist them to become self-directed in those 4 wheels. So we're going to talk about each one of these in just a minute, but just so that you can kind of see what this framework actually looks like from a schematic. What the Master Adaptive, institution looks like is, you're trying to foster critical thinking in the moment, self-reflection, self-monitoring even. So we're really using this now in our entry-level program, and we'll talk about how we've infused that here at Mizzou. But when can we allow our learner to be more in tune even with their own behaviors and their own kind of things ramping them up. So if they're starting to get frustrated, can they monitor that and then take a moment and kind of gather themselves and move forward instead of it going down kind of the downward spiral? So we're really working on that self-monitoring piece. We've found that with our residents. That's something that we really need to work on as well. And then the metacognitive piece, which is the thinking, right? Thinking about how one's thinking and what goes into that. And this is the big thing from utilizing this framework is the intentionality of the need for the self-directed learning. I think, and I'm finding this, I've actually got some good data on this because we're actually studying in educational research here in our entry-level students. We're actually tracking some of the qualities by the recommended outcome measures that the AMA recommends to track these over time. And one of it is the self-directedness. And so at the beginning of our entry-level program, we're assessing them, and it is a self-assessment. So it looks at their motivation to learn, their self-efficacy, their belief that they'll do well, their self-regulation, their cognitive strategies, and how they believe. And we always see when they first come in, they rate themselves way here. Then they go through a semester of DPT education, and then we reassess, and they're way here. So they over assess that they did really, really well. And then they adjust to the graduate level learning and they get exposed. And what happens? Oh, and then we need to coach them back up to what they need to be lifelong self-directed learners. And so those qualities that we talked about in the batteries, curiosity, so they need to be interested in what they're learning. And ultimately, we hope that by the time they get to PT school, that's why they're there. That's going to be their career path. They need to be motivated, but that motivation needs to shift from extrinsic grade to get into the program, right? And their high GPAs and kind of what they've been focusing on in undergraduate, to intrinsic motivation because this is their career and they need these skills long-term. Mindset is where the growth versus fixed, if you've done any work with the Carol Dweck information or her book or things, we've actually got that now. We've instituted it in our first year. So if they are doing a book club in their second semester of the first year, so after the summer of anatomy, they all are like, whoa, I've had to adjust. This is what's happening. They've identified their struggles and how grad school is going to be different. And now we're intentionally infusing book clubs to help build them and coach them in these characteristics. Resilience is a big one. We're finding that, every time you turn around, you're seeing burnout and it being mentioned. If you were at ELC last year, Nicole Piamonte really talked about burnout and why burnout happens. And it's not because we care too much or we have too much empathy. It's usually the organizational structure or the culture that you're immersed in. And so how do we teach our students to kind of control that and understand some of that, and that it's not because they're caring too much. And then you see the coach and then the learning environment being intentional and setting that up. And so this is what I was talking about previously. Some of these outcome measures or assessment tools can actually track these over time. So these are well-known, validated educational outcome tools that we actually now give our residents upon entrance into the program. Kind of see where they are, treat them as individual learners. Maybe someone's a little bit different in mindset as they are in the motivation. And then we do use that for professional coaching throughout the program as well. And so can these traits be fostered? Yes, but you need to think about some things. One of it is, what is the learner bringing to the table? What are their previous experiences that are going to influence, right? What they interact or how they interact and what they bring. And so we're seeing this a lot too. I'm sure if you're part of entry-level education, which you all are, you understand, like orthopedics seems to be an easier, I did my orthopedic shadowing hours. I watched this, I had an injury, right? They have some type of contextual, something that they can connect to, versus I just got done this morning teaching inhibition and facilitation of hyper and hypotonicity in neuro rehab. Sometimes that's an obscure construct. No one's ever felt tone or spasticity. And so the ones that are, what they bring to the table is a little bit more familiar, do understand it, grab it quicker, right? But how do we meet them where they are based on what they're already bringing, and asking those questions, and also having them realize I might need to spend a little bit more time on foundational knowledge because I don't have that experience to bring with me. And it's getting them to understand where they need to maybe spend more efforts early because they don't have that knowledge. Curiosity is another one, right? So this one I will say probably we're a little bit lucky when we interact with our residents, that they, they're very motivated, they're very driven. And so curiosity doesn't seem to be some of the things that we struggle with, but more so maybe in our entry level students, where somebody comes in with a preconceived notion that I only want to do ortho is my thing, I want to do sports, and then some of the other classes, they don't have as much curiosity. So how do we foster that everything's important, right? We were having that conversation prior to the webinar of, getting together your ortho and your neuro residents and having these deep conversations, because there's really not difference, because everyone's got a musculoskeletal system and everybody's got a neurological system. And how do you use all of your knowledge to better treat your patients? I already talked about motivation, intrinsic versus extrinsic, but we do know that when it is intrinsic, and higher intrinsic motivation is associated with all of these things. Improved learning, overarching better well-being, because you don't see it as something daunting and a task to check, but you see it as, oh, I'm super curious and I really want to do better at this. And then you can kind of see how mindset plays into it too. So fixed mindset is someone defines their performance as that's who they are and that's all they're going to be, versus a growth mindset where you look at all challenges as opportunities to learn. And I will let you know, we started doing individual coaching meetings with our first years this year, because we saw a lot of anxiety and stress about, if they got their first C in their life, they feel like that defines them as an individual. And so really shifting that mindset and having the conversation of grades are important unless you're in a true competency-based program. Grades are important, but they do not define who you are as a person and or a future clinician. And really working on their mindset that if you do have a challenge or a stumble, it's an opportunity to practice again. We've actually got our first years kind of chanting this, because we have our first lab checkout coming up. So we were, talking them up a little bit, like, if something goes awry, what do you get to do? And they are all like, try it again and learn. It was just funny yesterday. We had that after our little lab. Resilience is another one, ability to persist and continue in the learning process. Sometimes you're trying, but you're just not getting anywhere. And really knowing when to ask for help, of you are probably trying continuously, but maybe it's not in the right fashion of learning. Maybe you're still using that, I have to read everything and everything's important, and I'm highlighting and then I'm transposing all my notes over to my, right? All of those, I don't want to say immature learning, because it's what they are used to, but they're not transitioning into the graduate level learning and looking at that deep learning that's often talked about. And it's that superficial knowledge and the familiarity. Bill Cutter, if you've heard any of his work, will actually talk about the difference between superficial and deep learning, where if you read it enough times on a PowerPoint, you become artificially confident because it is very familiar. Yet when we ask you to answer a question that's clinically applicable, you don't have that deep understanding. And so that's some of that coaching that I'm doing currently, is coaching them into adjustment to learning. And we talk about what that looks like in a study kind of model as they're going through their courses. I'm going to turn it over to Lindsay now to talk about the coaching.
So going back to the master adaptive learner, as we talked about earlier, we're going to go through each one of these phases, the planning, adjusting, assessing, I'm out of order, planning, learning, assessing, adjusting phases, and how we can help foster curiosity, motivation, mindset, and resilience. So we're going to go kind of by each one. So for the initial one, so this, we originally used this for our residency education, but same kind of idea for clinical education. So in the initial planning phase, when the student is, sorry, the student is, has a patient that they're wanting to go in, that they come in and they're like, what is the area, like identify the gap? What is the area of knowledge that I need to grow in, or that I identified for myself? And what kind of resources do I have to help kind of fill that gap on my own? The learning phase where they're kind of going in and doing it, try to understand the gap and have a deeper conceptualization. Assessing, we're going to go try it. So they're going to go see the patient and you're going to be there as a coach to kind of give them a little bit of feedback in the moment and have them evaluate themselves, and then adjusting. So afterwards, kind of how did it go? How can I use this for not just this patient, but how can I use what I've learned with future patients I might have? And so one of the important things that we kind of realize in this whole mentoring process is relationship building. It is very important, the relationship between the clinical instructor and the student, that they feel that they're in a safe learning environment. This one, and I'll admit I have a little struggle with unconditional positive regard. So no matter what the student has done, that you think well of them, whether they're a concept they didn't know, the treatment session didn't go well, or even sometimes professional behavior issues that we've had to deal with. Sometimes even that you still think well of them is really important. That you give them freedom, that they have autonomy, that kind of helps foster curiosity. And then what we have kind of done in the residency side of things, I know things may seem a little bit different on the clinical side, but that when you want to show them things in a session, that you kind of ask permission. So like, there's a different technique for that. Do you mind if I show you? And that can kind of just help build that relationship. Of course, especially as a student, as a resident, they're fully licensed clinicians. As a student, they should say yes, they're practicing under your license, but it does kind of show a sense of respect in that situation. So as we talked about coaching in the planning phase, where the student is getting ready to see the patient and the role. And so in the residency setting, we have these pre-sessions and they're a little bit longer. I know you might not have the same time availability when you're seeing having students in a clinical setting, but that pre like session that you are like, what's this patient? What kind of concerns do you have? What's the plan? That instead of kind of telling them what they need to be doing, kind of find out where have they recognized that they might have struggles. Is it in transfers? Is it in knowledge of medication? Is it in knowing that they have the best treatment plan? And that the student help them recognize those gaps by asking questions versus just telling them the needs of the patient. And you can either do that with iSmart goals, or there's another one we kind of like that's like have them, what's the wish? How would they like this to come out? And what the obstacle is and what the plan is to kind of get around that obstacle. So kind of helping them in that pre-session that way. And we also really encourage diving deeper, not on a superficial level, but having them dig into that deeper.
And I think the biggest thing is a lot of the times they're looking for validation, right? They're like, well, what do you want to do today? Oh, I was planning this. Is that okay? They say a lot of, is that okay? Right? Is that, and instead of just, giving them yes or no, that's not okay. And I want you to do this and directing them, that's not them learning at all. You're just telling. Telling is very different than teaching or coaching. And so I may use that situation to say, okay, yes, I think that might be, but tell me why you think that that would be a good idea. And you're encouraging them to go deeper. What do you know from from the chart review that makes you think that this would be? So it's that deeper conceptualization and that deeper dive rather than, hey, I was going to do this and this and this, and is that good? Right? And you're just like, tell me more, right? And that's what we really are trying to encourage in this pre-session.
Right. And as well that we've had it in the past where they come in and they expect you to fill their gaps with stuff they could have filled on their own ahead of time, right? So sometimes they need a little extra coaching in that.
And this is where knowing this, living this for the last 2 years, I think it was like the first month that we instituted this in our mentor sessions in the residency. And I'm like, we should be doing this for everybody. This is not just residency education, right? Which is where it came from in the American Medical Association. This needs to be infused all the way down from the beginning so that our students are ready to jump into those complex environments quicker. without feeling overwhelmed. So what I've done, I teach in all 3 years of the program, first, second, and third year, but I teach the second semester, just a clinical evaluation course, right? Transfers, goniometry, MMT, documentation, and neuro exam. And so it's a lot of their first psychomotor practice with all sorts of skills. And so what I've done this year is, one, we've done the growth mindset, but I've also now infused small group academic coaching into how the adjustment to grad school should look like in the learning phases. And so I meet with them 3 times a semester, no more. We have a cohort of 60, no more than 12 in a group. And I take my whole day to do it. And we do 30 to 45-minute sessions. So I'm giving away a lot of my, day that I could do others, but I think it's so important. And we are talking about, where are you struggling? How are things going? And then giving them those tips, and also validating that what they're experiencing is normal. I think that's the other thing, is they struggle, and they think they're the only ones struggling. And so we are fostering and building a community of learners from that. And I've already gotten some really good feedback of thank you so much. I'm so glad somebody said that to me now, instead of waiting till the end of the semester when I'm now struggling to pull myself out academically. What's really funny is they're talking to the cohorts above them, and students are just stopping by my office and they're jealous. They're like, hey, how come you didn't coach us? And I was like, I'm happy to. Stop by in my office hours. Let's do it now. But it's actually got that trickle effect, which is really nice to see.
So coaching in the learning phase, getting comfortable with letting the students struggle. So being okay with it not going perfectly. And during our sessions, instead of jumping in if things are not going as planned or telling them what they should do, hanging back. But the other thing you could kind of do, and I will shout out to Eric Liebeck Brown, because this is for you, asking probing questions in the moment. So I was, as a program director, I go around and observe the residents mentor sessions. And I was like, this is a really good way to do it, where the transfer was not going as planned. And one of our mentors, Eric, was like, how do you feel like this is going? He's like, in the past, you mentioned to me, you wish you were doing it in a sitting position. Can you set this up differently? And asking more questions instead of telling them, move this here, you need to do this. So really asking those questions at the moment helps the student improve their metacognitive skills, instead of just and being able to translate that as well. So avoiding those quick answers and telling them what to do.
Which is really hard. So we just had this in our simulation lab over in the School of Medicine. I had my students do practice transfers with lines and tubes. And, watching it, and you're like, oh, this is not going to go well, right? The catheters on the other side of the bed, and this, us as expert clinicians, but not jumping in and correcting, because they're not going to have that awareness that, oh, what did I do wrong? But instead, exactly what Lindsay said, coaching them through, or, letting them, we had one yesterday where it was a transfer, but the wheelchair was way far from the bed, and letting it. And then after, as soon as the transfer was done, I was like, now let's take a look at that environment setup. And then the learner's like, oh my gosh, I could have moved that wheelchair so much closer. But because they identified their own gap after the performance, instead of me just telling them what to do, they're going to take that nugget and move it forward, looking at this framework.
And so in the assessing phase, kind of afterwards, important again to make sure that they feel safe saying what they feel did and didn't go well, and that you're not judging them. But also in that, not saying, well, you didn't have this right and you should have had that done, everything. Again, it's all about asking probing questions to help them recognize their gaps. So afterwards, you even generic, because I at first was a little bit more guiding and a little bit too specific, I was searching for a specific answer. Instead being like, what do you think went well? What didn't go well? What gaps do you see that you may still have to bridge? And those type of questions, being a little bit more generic. And when you give them feedback, and I struggle with this, giving them a mixture of positive and constructive feedback. A lot of times I've focused just on the constructive feedback. And I even realized that one time when I had a student that was way too excited, when I gave her a little bit of encouragement, that I realized I was really too critical. So I gave her that mixture of that positive constructive feedback. Make sure you're balancing both. And then facilitating, recognizing those patterns and gaps. So being like, I've seen a couple times, it seems like I've noticed a pattern that you're having struggle with patients who have additional psychological barriers or psychomotor, psychosocial barriers or something like that. Just helping them pick up on when there's a trend maybe.
And then asking them the why there is a trend. What makes you uncomfortable with dealing with somebody who maybe has a lot of anxiety? And then getting it there. And then it cycles back to that wheel of, well, now we've helped them identify the gap, and then they should be self-directed in looking at resources, pulling articles about how to have those conversations. How do we infuse cognitive behavioral therapy, right? All of those things that they can then find the resources on their own.
And then from that point, we really want them to be able to take whatever they're learning and apply it in multiple different ways. So you could be like, well, what if this was a patient who had trach? What if this was a patient who didn't have had a communication barrier, so that they can not only learn what they're doing on that specific patient, but that they can generalize it to other patients. And also, just the systemic impacts as well, you could use in that situation.
And this is where some of that leadership comes in too, because they may be seeing trends in their clinical setting that they're out, they're working here, but they might be seeing trends. And then it's well, what if you were to go talk to the maybe, speech therapist? How could you foster that communication? So then you're bringing in the interprofessional collaboration as well, and those leadership skills. Especially, it's really easy to, and we all probably have been there in our career, complaining about something and it not changing. Well, what if you were to actually go and have that conversation and spark that, right? And now it's the leadership, or they're always seeing a trend, you know what I mean? Patients are coming down from the unit and they're always seeing a trend that something's happening from nursing, or, but then go and be an educator and be a leader and try to make a difference for our healthcare systems.
So I did that. Oh, in the session, sorry. Having them identify what they want to focus on is a big part in our residents. So we, instead of saying, we need to work on this and this and this, this is what I want you to get out of this session, that they come in and they identified what they would like in their own session. So
let them identify where their biggest struggle and thing that they want to work on for the day. What's the goal for today? And I think some programs definitely foster this through goal planning sheets that they use every week, maybe potentially in the clinical setting. But on our mentor prep form, we've actually got, what is your focus? What would you like additional help with for today's session? And it lets that learner drive the ship instead of somebody telling them, I want you to do this today. And then that kind of puts that learner at the center, which is really nice. And we've saw really great kind of outcomes with that. I've already alluded. So, you've got academic versus clinical coaching. These are no different, right? It's the same types of struggles and uncertainties, and they're identifying of the gap. It might look in the academic setting though, like I also teach pathophysiology. And so we don't have a basic physiology course within our curriculum. We are relying on their physiology knowledge from undergrad to pull forward, but that may look different depending on where they did their undergrad. So I want them to start, hey, if you don't have good foundational knowledge of the, renal system, you may need to go back and find your resources, get yourself up to speed, and then let's talk about pathophysiology. And so I will often, if you need extra resources, here are a couple of things that you can maybe watch, right? Like here's a cartoon schematic of something, or you need to remember the blood flow of the body. And give them the prompts, but then it's up to them to be self-directed to use them or not. It's not required for everyone. They need to pick and choose what they need the extra help with because of their gap identifications. But you can see how that translates right into the clinical setting as well.
So in it, just making sure as a coach that you're leaving your personal agenda at the door, that you judgment free. This is all about the safe learning environment, that you give the learner autonomy, and you are aware of when you come in and have a bias of your own. So pretty much just the safe learning environment.
We got interesting. So we had a Zoom accreditation site visit. So our accreditors for ABPTRFE were on Zoom. And so we took a little iPad into the room and they observed a mentor session. And sometimes you even don't think about, you're just trying to be helpful. So we got feedback that, the mentor was helping take off the SCDs, right? And going and getting the walker and like all of the things that you would need to do independently in clinical practice. And you're just naturally helping because you're there versus really stepping back and letting them do the whole picture of it, especially if it's a terminal clinical and they are expected to be independent, right? Upon graduation, how much are we still unintentional controlling behavior, right? Like, oh, this is, and I catch myself doing this all the time. So we run a pro bono clinic within our curriculum for our entry-level program. And so I'm a clinical instructor in there. And I some days I have to sit on my hands, right? To just not jump in and really not, let them try to figure out like, where is the blood pressure cuff in the clinic? Like when you go to a new clinic, what do your first day? You go searching for all the equipment or you familiarize yourself with things. And that sometimes it's really, really hard, but really just kind of doing a check, internal check of how that's going. The learning environment is big too, and this is going to look different. Like you can't apply this as a rule to every environment because it's so different. Your learner is going to come with previous experiences. They're going to be along the continuum of those characteristics. They might be really motivated, but have this fixed mindset that everything that goes wrong defines them. So where would they need a little bit more coaching? Probably more in the mindset side of things. Your organization, are you an outpatient orthopedic clinic that's expected to see 20 plus patients a day, right? How are you going to coach your learner to flourish in that environment? Resources, what types of resources do you have? If you have the best technology, great. But if you don't, how can you be innovative and still try to think outside the box? There's going to be variability across settings, and then even the qualities our coaches bring to the table as well. So really, when we first started this, we did training for coaches, and we did a retreat where we just talked about this coaching model and we addressed it that way before just saying like, here, this is what I want you to do and sending people out into, good luck. What I really want to do for the last little bit, we have about 5 minutes before we open it up for questions, is really talk about what this might look like in a clinical setting. So this is a residency example, but all of you will say, this looks just like clinic, right? So I don't think it's gonna be any different. So we had a resident who was struggling with identification of their own gaps. They really showed up to sessions, and if they didn't know the answer, they didn't fill it out on the prep form or search for the answer. They expected the mentor to fill it in for them. Very much a passive receiver. Well, it's your job. Like, I'm in this residency, you just need to tell me what this is. Very much checking the boxes and filling out the forms that lack depth. Oh, I just put it in there. Here's the medication. She would list meds, but not actually list side effects or what could this be? What should we look for in the treatment session because of these meds? But had multiple feedbacks related to performance of all of these things, and we weren't seeing any big changes over time. So this was me. I was in an outpatient setting. We had a very complex patient, and we were doing our pre-session, going through like, okay, what do you know about this patient? What are your thoughts? Where are you going with this? So it's a complex patient with a stroke plus a traumatic brain injury. So a stroke originally, and because of the fall imbalance, had a fall with a subdermal hematoma. So it was a CVA with post-TBI. Multiple comorbidities, diabetes, hypertension, depression, CAD, PVD, right? Like these are our typical patients that we see anyway in our outpatient neuro clinic. They resided in a SNF, but didn't qualify for care in the SNF. And so was coming to our outpatient because the physiatrist said that he wanted to be better in walking and be a less burden for his CNAs that were having to walk with him every day if he wanted to do any walking. To decrease the burden of care. While going through the chart review, there was a recent admission to the emergency room with chest pain, and the patient was found to have first-degree heart block. And this was within like 2 weeks of us seeing an outpatient. And when looking at the interventional strategies of everything, the only thing the resident wanted to do was use high-intensity gait training for this patient. And so many of you, especially my in those working acute care or cardiac units, that first-degree heart block should have been a red or yellow flag to know more about that and not just jump to high-intensity gait training. And so I stepped back, I kind of coached and asked well, what are your thoughts of different things. What are you thinking with this recent admission? Is it still appropriate? And asking those probing questions. And she kind of said, well, oh yeah, I guess I should have thought about that. Well, maybe high intensity is not. I'm just going to try to get through my exam today. And so I sat back and let her kind of go through things. Incomplete neuro exam. So she was kind of all over the map. We had just talked about the importance of vitals, especially somebody just being admitted for cardiac reasons. And she got her subjective and then jumped right in, no baseline resting vitals, nothing in that, type of thought process. And she was having difficulty. He resided in a SNF. He was a professor emeritus, retired, and he wanted to talk. He, had this great camera and photography and different. So she was having difficulty keeping him on task. Like I said, inconsistent vital monitoring. There was a point in time where we're getting towards the end and she's got to look at some functional movement and wanted to do just kind of some ambulation, maybe a 2-minute walk. And she started just walking, and then he is retracting as far as shortness of breath, like visible retractions. And it was one of those moments that I learned from Eric and said, so tell me how you think his hemodynamics are right now. And she was like, oh my God, I forgot to measure them. I don't have a pulse ox anywhere near me, right? And so it was that in the moment, I had to be comfortable, right? Not to jump in, cease everything, have her sit the patient down, but instead bring her own awareness of those gaps in something that she could improve on. And so because of that in the order, she was unable to finish the evaluation because that patient, after just that 20-foot walk, was exhausted and needed the recovery. And at that point, she had then gotten vitals to monitor and different things. And so post-session debrief, I just want you to think about, and we can open this up for our discussion, how would you have fostered reflective skills? This would have been really easy, right, afterwards to say, well, let me tell you what you could have done better, right, and just gone into everything that way. But instead, how do you turn it into a coaching moment? So some of the things that I said were, what were you told? Or what did you see in the electronic medical record or recent, kind of history that should have had you like a yellow or red flag? And she's like, well, the first degree heart block. And then I was like, so how much do you understand about first degree heart block? Well, I don't. I think, you know what I mean? Like, what is it? And so then if you had dug deeper into first degree heart block, how would that have changed your order or sequence and how you would have done things differently? And so we did a lot of coaching that way. And then we kind of went down the professional development realm of like, tell me about how you're prepping for these sessions. How are you feeling with this? Well, I'm just overwhelmed. And, it turned into this like time management underlying issue than anything else. And that's where, personal coaching. So it turned into time management, preparation. So that's where I say academic and clinical coaching are no different. She needed more of the academic backside coaching so that she could organize things, prioritize, and then what is that stress and anxiety management that is causing a negative learning environment. So I feel like that was speed dating as we were kind of going through that. But what we've learned is of all of this, and like I said, we took it from residency and we're infusing it into our entry-level program now. We're doing some piloting this year of kind of like working out the kinks before we introduce it as a whole in just a couple courses. But it takes a village and everybody has to be speaking the same language. Just like if we think about learners being exposed to like, are they just doing things because that's how their preceptor or their CI or their faculty want it to be done? Or are we giving them, like Lindsay said, that autonomy to come up with their own ideas? And as long as it makes sense and they can reason, let them go with it and trial it. And then it's that reflective piece afterwards when maybe it doesn't go really well to foster that adaptability. Communication is key, that growth mindset and really being a coach in that. And then that constant revisiting of the framework, because it's easy. What we found is to slip back into kind of the comfortable, as much as we're asking them to be uncomfortable, right? We as well, some of this, Lindsay talked about it. I even too, I was a control freak. Like I said, I have to sit on my hands, right? How, we have to be okay as educators being uncomfortable and not being the sage on the stage or the expert in the room and letting these students actually experience some of this uncertainty, struggle, grayness that we know is in clinical practice, and we kind of protect them and make everything perfect, but we want to make sure that they know how to adapt in those times of uncertainties and struggles. And so, okay, I think we're pretty okay on time.
You guys did great. Thank you so much. What wonderful topic, wonderful execution of it as well. I'll start, and Lisa and Jacqueline, feel free to jump in as well with some questions. There was a number of just praise. We'll start there. Everyone was just throwing a lot of kudos, Eric and Chrissy especially. The question I want to pose that was in the chat was how we're balancing, and perhaps it's a little bit more to you, Lindsay, how we're balancing the competency-based education push and still allowing the learner to guide their own goals for learning within, a session or a week or a month, like how we're balancing those two. I think the fear being, if you let go of some of that control, how do you stay on track?
So, I mean, I guess my best way for from a clinical side of things is how we're doing our pro bono clinic. I'm a clinical instructor in one of those clinics. And typically they come in the pre-session with their plan on what to do. I'm asking them some questions about, well, have you thought about this? Have you thought about that? What about this consideration? And during the session, there's a lot of struggle that goes on, just the last session I had. Clearly, they did not plan more than a couple activities. And when that didn't go well, it was kind of deadness and silence. And then it was one of those situations. There was a patient with a spinal cord injury that it was like, okay, does he not have enough muscle activation strength, or is it not enough range? So I was like, oh, that didn't go well. What about it didn't go well? Well, he just can't do it. Well, is it this or that? And in the session, they couldn't really tell me how to assess it. So at that point, I'm like, well, let me show you. Is it okay if I show you that? And I showed them in the session kind of, well, this is how let's assess. Does he have even enough range available, And then from that, then they're like, oh, okay, it's this. But then afterwards, kind of taking them and it's like, how did that go? Well, didn't go so how, where are those gaps? So that's kind of how we're using it. Now, as far as the competency based or not, that's probably a little bit more of Becky's area to address.
I mean, we're doing competency based in residency. So we now have the core competencies in residency education. And so that's where it's on a scale of 0 to 5, and maybe there were 1 and there were 1, but by midterm, we have to get them to where a 2. And so, that might be a little bit of extra time, a little bit of extra coaching and identification. That is probably here. We've started the talk about competency-based education in our entry-level program. And I think that's one of the biggest fears of faculty is well, what if you've got somebody who's struggling and they're not going to be caught up in that week, but the next week there's new information and now they're way far behind. And I think that is where you've got to have these individual learning paths. I can't wait to talk to Stephen Ambrose, right, over at WashU, who's right down the road from us. Sounds like, we've talked to some of their faculty and they're like, talk to us when we have our first cohort graduated. They're just, because it's the first time you're doing it. But I think this is where if you look into medical education and competency-based education, you have that pre-assessment, right? How are they doing? For some learners, because of their prior learning experience, they can go right to this level, and that's where they engage in information. But then you've got ones that don't have that same, so on their pre-assessment would score lower, then it opens up a different learning path with a little bit more of their gaps to be filled on foundational knowledge before they can get to that same level. And that's where, we need learning management systems that can operate in that way with the pre-assessment, and based on the score on their assessment, different learning modules are open for that individualized learner, which then does what to the learner? It puts them at the center where you're truly giving that student-centered approach for that individual person. And then it is also a lot of extra work on faculty when you're trying to get caught up so that they can meet the competency, that the criteria that they use to go out on clinical, right? For here, we use the KSAs that ACAP actually published, right, for the knowledge, skills, and attributes prior to first-time clinical experience. So I actually infused that within the first year, and we've got some students that don't meet some of those, and we do individualized coaching outside of our normal time to get them where they need to be. But ultimately, if they can't get there, it's a hard decision to say, we might need to decelerate and slow you down a little bit. That's the question of the day. If somebody can answer that, I think they'd have $1 million. Lisa, help me out.
I can't help you out. I was just going to ask the next question. So there were several questions in the text in the chat about resources, and I assume you have resources about how to learn how to coach, how to, is it best to have the same faculty member be a coach, you know, all about coaching. Lindsay, you gave us a great overview of what the coaching at different phases of the master adaptive learner, but they were looking for more resources, including your dissertation, Becky.
Oh, I
Can
would
you put that on the
happy. Absolutely. And mine was specific to fostering self-reflection in entry-level DPT students and how we did that through design, both in academic and clinical settings. So I am absolutely, and interesting, you guys will love this as DCEs. I presented this at CSM in a platform presentation. And by doing the intentional educational intervention that we did to foster some of these metacognitive, that was the first cohort that the DCE got no affective behavior calls. So like as a DCE, you're like, oh my gosh, right? That's what I think. I had 4 or 5 DCEs come up afterwards and be like, please tell me what you're doing, right? Because that was the things that were being dealt with. But because of what we did in fostering that self-awareness and the self-monitoring, they were able to self-assess and not go past and over the deep end. These are some resources from the American Medical Association. We are using these as part of our
monthly mentor meetings. So like of course, the Master Adaptive Learner itself is a fantastic resource.
textbook. Yeah, there's a ton, but then there's a coaching book too.
Yeah, the AMA came out with a supplementary book that's coaching and medical education that just came out, I want to say in April. So that is a fantastic resource. And from that, the AMA created these, they're like 15 minutes or less little videos on different aspects. It could be skills building a relationship, dealing with like unmotivated, like not being motivated, or different behavior things. And so there's these little bitty like coaching videos that, like Becky said, what went wrong, let's reflect. It always says, let's reflect, and what went well. And so in our monthly mentor meetings, we've been watching those videos and then discussing it afterwards. So I think those are excellent resources, and that's what we've been using right now.
I think the other thing to talk about is the coach in a group of coaches, or as you're all learning and adjusting to this, being in a safe environment. We talk about safe learning environment, being in a safe, supportive environment to be vulnerable about your own struggles during some of this development and what you're doing, and admitting and saying like, oh my gosh, I totally jumped in and I shouldn't have done it. And oh my, you know what I mean? Like having a support community around you as you're learning this new way of doing it, especially if, you know, you're the one that likes to show first and then demo, and, you know, absolutely. I think we do this naturally of like, we'll call after a session and be like, oh my gosh, I should have done this. This could have gone better. Or, you know, we kind of talk about that a little bit too in our mentor retreats and things, but I think that's also a very like good resource to think about.
I was just going to mention those through the AMA or the GAAMC are free. Those videos, those coaching videos, Lindsay, if you didn't mention that already. So, and they really are a great resource.
And we will, I already talked about this to Matt, we will share our PDF afterwards. I'll send the PDF to Matt, and then this can be, you can have all of the slides and the resources too.
Yeah, great transition. I'm sure we could have this Q&A go for forever today. I think this is actually where we'd love to rest. To Becky's point, this will get posted onto the ACAP resource pages. I'll reshare those links here in a second. The presentation itself today will also get loaded up to YouTube, so feel free to share it broadly and widely for sure. And also listed on here are just some of the upcoming webinars, some of the NCC or clinical education pieces that are happening at ELC that's upcoming. There's one more slide. Let's see if we can get it up here. Becky, can you close your screen for a second?
Yep.
The screen share.
There we go.
I'll see if Lisa has another slide she can show for us. A couple of the resources that I just entered into the chat are specific to some work that ACAP globally is doing. So if you haven't been to the Excellence Framework website, it's definitely a resource to spend some time on too. As well, those that have kind of touched it already, there was the institutional profile survey last year for 2022. This website shows you kind of an update of that information, where we're at and what the planning for the 2023 is. As well, there's a ACAP-led pre-con at ELC, and the information's on that kind of third tab there. So we somehow packed all of this information into an hour. Well done to our presenters. Thank you, Becky. Thank you, Lindsay. This is incredible information. I'm confident there's going to be some offline conversations that are stemming from this, and we'll kind of tie you guys back into that as it's occurring. Thank you wholeheartedly from the NCCE. We appreciate it. Appreciate your expertise and the knowledge as well. And if people are out there, have ideas, have future things that they'd like to hear from the group, please send them our way. We'd love to share it with the whole ClinEd community. So thank you, everyone. Have a great afternoon.